Sudeep sir.
Hello, good morning.
Good morning, sir.
Good morning.
Okay. So
Bye,
we are starting this program live, sir. So
yes, sir.
To start with the program, I would request you to give some kind words to start with this program, sir.
Good morning, everybody. Respected seniors, my dear colleagues, the faculties who has organized, and all my dear attendees. At the outset, I would like to thank the Dr. Vivek and the entire academic team for organizing this topic. And I'm sure this patellofemoral instability is a very, very confused branch still for many of our colleagues. And I'm sure this topic is going to clear most of our doubts to most of our participants. So without any delay, I'd like to request Dr. Vivek to continue with the session. Thank you very much, Dr. Vivek.
Thank you so much, sir. So we'll be starting our scientific session. May I request Professor Amit Joshi for his first talk? Thank you so much, sir.
Thank you very much, my dear friends and colleagues. After a long time, probably after making 500 presentation, last week I was quite stressed when I was going through doing all the literature search, basically to simplify the approach towards the patellofemoral instability. So I have two talks. First, I'll start with the different phases of patellar dislocation, its anatomic and the biomechanical understanding, which is the basic understanding for the patellofemoral instability. So I'll basically focus on in my first talk about the classification of patellar dislocation. What are the classification? How to observe that classification, and understanding the patellar stability. So how patella stabilizes in place. And in that, I'll talk about anatomical and the biomechanical correlations. If you go to literature, you don't need to read this, but understand that there are lots and lots of classification. Classification of Chortel, classification of Dizor himself, classification of Force. So there are various classifications, and these classifications are based upon various factors. Some people talk about age, some people talk about direction, some people talk about cause of dislocation, and so many other things. This is one of the popular classification done by Sheetal Parikh, who has a beautifully written book, and he classifies pediatric patellofemoral dislocation in a different way so that the treatment can also be identified. Another classification by Forche, again probably the latest classification which they published in 2017, and probably they have divided this into 5 types and then tried to give guideline for the treatment of the patellofemoral instability. Okay, so a summary of all my 4 days of literature about the classification is I found more than 50 different classifications, and they give various recommendations. So I was thoroughly confused about what to do with the classification and how to deal with them. Okay. So how I thought, came with the conclusion of around reading about 100 literature, what I thought that probably if you divide your patellar dislocation into traumatic, atraumatic, probably most of these classifications fall into this one. So traumatic means when you have a direct trauma. So someone falls, sports injury, football lands on the knee, falls on the knee joint or hits patella directly, and someone or something comes and hits the patella, like someone sits on patella and then it dislocates. This is type of a direct. So these type of patellar dislocation can be categorized into the traumatic. The other group is indirect trauma. So someone falls, but he doesn't fall and hits, but because the patella dislocates, that's why he falls. So it is kind of a twisting, while walking, this kind of thing will lead to the dislocation, twisting and fall. And there is a third group, which are a little bit doubtful cases, so that you don't exactly know either it is a traumatic or it is a atraumatic. So now you classify all those classification, 50 classification, everyone falls into, all the classification falls into this group, traumatic, atraumatic, and the doubtful cases. So what happens when the patella dislocates? So when the patella dislocates, we all know that MPFL is the major restraint to the lateral subluxation or lateral dislocation. So when patella starts dislocating laterally, the patellofemoral MPFL stretches and it tears. What is important to know that patella, it attaches in patella, mid-substance, and in the femur. So it can tear into any of the places, either in the patella or in the mid-substance or in the femoral attachment. And as the force continues, the patella dislocates. So this is important to know that patella has attachment and where the MPFL has torn, because this is important from the treatment point of view. So most of the time what we see and what we think is patella has dislocated, MPFL is torn. This is right. But you have to understand, we all have to understand that MPFL tear may be a cause of patellar dislocation or recurrent patellar dislocation, or it can be an effect of patellar dislocation. For example, if it is a traumatic, then patella dislocates, your MPFL is torn. But if it is a atraumatic, suppose someone is having a trochlear dysplasia, in that case also patella dislocate. But in this case, MPFL is secondarily torn. It is not a cause. MPFL is not the cause, but this is the effect of dislocation. This concept is very, very important when you start planning your surgery, when you start planning your treatment for this particular patient. So whenever you see a patellar dislocation, we must always look for the cause of patellar dislocation. So understanding the patellar instability in anatomy based upon the cause of patellar dislocation is very, very important. So first, you see the patellar tracking. So in 0 to 20 degree, patella articulates with the flat femur. So in this place, it's the soft tissue which provides stability. In 20 to 30 degree of flexion, it engages into the trochlea. And when it goes beyond 30 degree, then it falls into the trochlear groove. So based upon at what degree patella dislocates, then the causes may be different. So one classification is not going to cover every type of patellar dislocation. This is the reason why we have to understand the biomechanics, we have to understand the anatomy. This is just theoretical. We all know that whenever there is a joint dislocation, we talk about the static factors and the dynamic factors. I'll not go into that because these are all theory. But what practically you see, this MRI cuts at 0 degree, 10, 20, and 30 degree of knee flexion, you will see that at 0 degree, the femur is flat. In your first picture, you see that the femur is flat. So in this place, all stability is provided by the soft tissue structures. That is very, very important to understand. When it goes into flexion, you see the shape of the femur starts changing. And at 20 degree, probably your trochlea appears and then your patella goes into the trochlea. So if it dislocates into 20 degree, the reason is completely different. So beyond 20 degree, when it is about 30 plus degree, your patella has to sit into the trochlear groove. So directly, the stability at that point is a bony stability. So if your patella is dislocating into the flexion at 30 degree, the primary cause is the bone. Whereas if your patella is dislocating at 0 to 20 degree, the primary cause is the soft tissue, which is very, very important to understand and plan the treatment. So that is why I summarized all this classification, the causes of dislocation, into the 3 groups, which I always use for planning my treatment. Number 1 is the soft tissue does not bring patella into the trochlea. So there is a pathology of the trochlea, soft tissue, which doesn't pull your patella into the trochlea and then it gets dislocated. That is the number 1 cause. And the most common causes of this is MPFL tear and the patella alta. The second important cause is the trochlea is abnormal, or trochlea itself is a pathology. Your soft tissues are normal, but where the patella has to engage and stabilize, that bone that is trochlea is not normal, it is abnormal. That means trochlear dysplasia, then this is a completely different. And the third cause of patellar instability is abnormality of the bony alignment. Either it is a femoral torsion, or it is a tibial torsion, or valgus deformity. This will lead to the dislocation. So if you classify all the causes and put your causes into these 3 groups, you will definitely identify what is causing the patella dislocation. Let us talk about the first one. Soft tissue not able to bring patella into the trochlea. MPFL I will not touch about. So this is an animation in which you'll see that what happens if there is a MPFL is torn, your lateral structure starts overpulling, and then your patella starts from the lateral side. So when it goes into the trochlea, trochleum pugnibellum, what happens? It hits the lateral trochlear bump. Once it hits the lateral trochlear bump, then your patella falls into the lateral side. So here, clearly the pathology is soft tissue not able to pull the patella into the trochlear groove. So in this case, probably if you repair, you कसैले admit गर्दैन नि त्यहाँबाट बाबु? के भयो विवेक, तिमी अर्कोमा लगइन गरे भएर यो सेसन इनएक्टिभ हुन लाग्छ भन्दैछ। ओके गर्दियौ? आइराछ क्षितिज? Okay. So in this case, when there is a trochlea is normal, when there is alignment is normal, only soft tissue MPFL is torn, your MPFL will work in this case only. So MPFL repair or MPFL reconstruction is not the answer for all patellar dislocation. This is one point. Okay, okay, let's talk about what happens in patella alta. Since your patella is very high riding, even in 30 degree of flexion, what happens? Your patella doesn't come down and doesn't engage into the groove. So what happens? Patella remains unstable even at 30 degree, and then it is, there is a chance of dislocation. So this pathology has to be understood. In this case, if there is a patella alta, whatever you do, if you do only MPFL reconstruction, the patella is not going to come down. So chance of recurrence is very, very high, which I'll talk about when I talk in my second. So this, you see that this is one of the example of the patella alta, and then the patella dislocates in extension. You see that the J sign, when he flexes, what happens? The patella comes into the groove. So this is clear a patella alta. So if you do a TTO, then the patient will do good. Again, MPFL alone will not serve here. You have to do a TTO plus MPFL because of the patellar dislocation, because of the patella alta, patella has dislocated and the MPFL now has become insufficient. So here, MPFL is not a cause, but it is a result of dislocation. This is very important to understand. Trochlea, Dizor has talked about all these things. I'll not go into detail. Probably my other colleague will talk about trochlear dysplasia. So this is, okay. So this is one of the, CT scan of our patient who had a bilateral trochlear dysplasia in whom we did a trochleoplasty. So this patient underwent multiple surgery, but all of them were soft tissue surgery. We'll talk about. So what happens at 20 degree, the patella, enters into the trochlear groove. So in the entrance, there is a bump or there is a flat trochlea. What happens? The patella doesn't enter into the groove and your patella is dislocated. So in this case, whatever soft tissue you do, it is not going to heal. Probably you need to approach differently. So this is the patient in which what happens, you see very carefully, the patella is coming down up to 80 degree, and then as it goes, the patella dislocates. So here the problem is the trochlear groove. So patella is dislocating in the flexion. So this is important to understand. When the patella dislocate in extension, when the patella dislocate in flexion, the etiology is completely different. The final group, the third group, is abnormal bony alignment, does not allow patella to engage into the trochlea. So if your alignment, bony alignment is abnormal, your patella will never go into the trochlea, which is the main point where the patella stabilizes. So for example, if someone is having valgoid knee or femoral version abnormal, or the tibial version abnormal, rotational malalignment. So in all these cases, patella will not go into. For example, this is an animation. You'll see that what happens in the valgus, if the knee is valgoid, the patella is already lying in the lateral position. So again, from the lateral position, when you flex, what happens? It hits the lateral, the apex of the lateral femoral condyle, and your patella will dislocate on the lateral side. So whatever soft tissue reconstruction you do, it's not going to help you out. Same thing happens in the external. Same thing happens in the external rotation as well as in the internal rotation of the tibia. So if there is a femoral rotation, what happens? When the patella goes down, the femur is rotated internally. That means your lateral condyle is coming first into the contact of the patella. When it contacts that bump, then your patella dislocates laterally. So in this case also, again, to emphasize that bony is the main important pathology in this particular case. Same thing happens when there is a TTTZ distance is increased. So TTTZ distance, when my colleagues will talk about, this indicates that your patella is, your tibia is rotated externally. Your tibial tuberosity is rotated externally. So there is an outward pull, there is a lateral pull always into the patella, which again makes your patella to hit into the lateral femoral condyle, and that dislocates. So this is again what happens if your tibial tuberosity is laterally, patella comes, hit into the apex of the lateral femoral condyle, and the patella dislocates. So this is one of our patient in which she had a clear-cut valgus, but patella was dislocating on the lateral side, which is a very classic example. So to conclude on anatomy and biomechanics, there are several classifications of patellar instability. None of these are perfect for decision making. Every classification has some, flaws. Etiological classification is very, very important for investigation purpose, not for the treatment purpose, but for the investigation purpose, where your investigation has to head. And the traumatic, if it is traumatic, your investigation goes in the line of identification of the MPFL. If it is atraumatic, then you have to identify probably the alignment issues, rotational issues, trochlear dysplasia. And in case of doubtful cases, I always do an extensive, investigation so that I identify the cause of dislocation. Why patella is dislocating? It's very, very important question to ask to our each and every patient. Is it because of the soft tissue, which is not able to bring patella into the trochlea, or it is because trochlea itself is a pathological that has caused soft tissue damage, or the limb alignment is out of the tracking direction? So the tracking soft tissue tracks patella into one direction, and your alignment of the limb is in the different direction, which is causing your trochlear groove into the opposite direction. If you think on this line and investigate and answer all these questions, probably you have an answer to the cause of the recurrent patellar dislocation, and then planning of your treatment. Thank you very much. Thank you.
Thank you, Amit sir. That was an excellent talk. So, if there are any questions, both from the audiences, delegates who are present here, or who are joining us live. I think there are no questions, so we'll proceed with the second presentation. The second presentation is by Dr. Batra. We will be discussing about the role of X-ray in case of patellar instability.
Yes, sir. Sorry.
Good morning. Good morning, respected all. My topic for presentation is how to analyze X-ray in patellofemoral instability. As Amit sir said that he was very stressed, how to simplify it yesterday night, he was very stressed, and you can guess what had happened to me in this very enigmatic patellofemoral instability topic. And I would say it is silent epidemic, and it is very difficult to analyze X-ray, and we are not used to go through deeply into this topic. And there are so many things which we frequently missed in X-ray. So to analyze the X-ray in patellofemoral instability, it is the X-ray view. X-rays are not other than knee X-ray, which can be AP, lateral, or axial view. And anterior-posterior view provides less information. It is very less informative. However, this can provide so many information regarding the partite patella, multipartite, bipartite patella, and osteochondral fracture of the median patellar ridge, loose bodies also. You can see in this one, this first figure, this is the AP view of the knee, which gives very less information about the patellofemoral condition, right? It seems fairly normal in this case. But the same knee, if we if we see in the lateral X-ray, there is a avulsion fracture of the inferior pole. So AP view is not so much informative, but this partite patella can be seen in the AP view. This is the bipartite patella, this is multipartite patella, and loose bodies can be seen in the AP view. But there are very less information we can elicit from the AP view. And lateral view is very important in this case. So we can elicit so many things from the lateral view, patella condition like patella alta, patella baja. There are so many indices that we can elicit from the lateral view. So many signs and so many lines can be seen from the lateral view. So first one is the Blumenset line. This is the line that is drawn from the intercondylar notch area here. From this line, this is the Blumenset line. This is drawn in the knee in lateral view, true lateral view in the 30-degree flexion. And if the tip of the patella here, tip of the patella, that is inferior pole of the patella, touches this line, this is normal. This is normal patella. And if the patella is quite high above this line, then it is said to be patella alta. And if the patella is lower than this line, or this patella is lower than this line, then it will be said as patella infera or patella baja. So another is insult solvity ratio, which is very frequently used to assess the patellofemoral instability. Here, 30-degree of knee flexion, then this line is the longest possible distance, that is longest diagonal distance of the patella, superior pole to inferior pole. And this line is patellar tendon length, that is from the inferior pole of the patella to the tibial tubercle. And here also you can see in the X-ray, this is the one line, this is one line, and this is another line. The ratio between this LT, patellar tendon, to the longest possible distance, that is diagonal distance of the patella, should be 0.8 to 1.2. This is the normal ratio. If it is more than 1.2, then it is known as high riding patella or patella alta. If it is less than 0.8, then it is low riding patella, or it is patella baja. And another very important index is Caton-Deschamps index. Here, the patellar articular, the length of the patellar articular surface. This is the patellar articular surface. You can see in the X-ray also. This is the articular surface, and the another line is from the inferior edge of the articular edge to the anterior superior edge of the tibial epiphysis. This is the bony margin, anterior superior bony margin, and this is the length. So this B by A, normal B by A, this line to this line should be, the ratio should be 0.6 to 1.2. And if it is more than 1.2, it is said to be patella alta. And if it is less than 0.6, it is known as patella infra or patella baha. Another important index is blackbone pill. Here, what we assess is, this is the distance of the patellar articular surface. This is length of the patellar articular surface, and another reference line is made from the tibial plateau here, and the distance between this line to the inferior edge of the patellar articular surface. So this line to this line, that is A by B ratio, should be 0.54 to 1.06. If it is more than 1.06, it is patella alta, and if it is less than 0.54, it is patella baha. And there are so many indices, regarding the assessment of the patellar instability. One is modified initial solidity ratio, which is given by Grell-Sammer and Meadows. This is the where everything is same, but it takes the distance of the patellar articular facet length. And another is Level-Lauren index, Link-Law index, D-Carvalho index, Pochino index. These all are for academic interest, which I'll be not discussing today. And another very important thing is various lines and signs. This is very important to know about the trochlear dysplasia and patellar instability. Before reading all these lines, let's see this axial view. This point is the highest point of the lateral femoral condyle in the axial view, and this is the highest point of the medial femoral condyle, and this is the trochlear line, and this is trough of the trochlear line. So if this view is seen in the lateral X-ray, if this knee is seen in the lateral X-ray, two lateral X-ray, then these two lines, these two condylar points overlap here. That means both the condyles overlap here, giving one line. This line is known as anterior condylar line or anterior femoral cortical line. See here, this line is seen as the single line over here, this line. And this star shape, this is the trochlear line, and this line is said to be trochlear line. This is the trochlear line. So what happens? We have to see these two lines to assess the instability or trochlear dysplasia. If this medial condylar line, if this medial condyle is very hypoplastic or very small, then what happens? These two lines will not overlap. So we will see this line at this point, over this point, which I'll be discussing later on, this line, and that is known as double contour sign. And if this is shallow, or if there is bump, if the trochlea is flat, then what happens is this line, anterior condylar line, and this line will be crossed each other. That is known as crossing sign. We can see here, this line is trochlear line. This is anterior condylar or anterior femoral cortical line, this line. You can see here, this blue line is trochlear line, and this red line is condylar line, anterior femoral cortical line. Now, see here, this is the trochlear dysplasia desert type A, where the trochlea is shallow, and this crossing sign, there is a crossing sign. This is a condylar line, and this trochlear line are crossed over here. See here, this is known as crossing sign. This point is known as crossing sign. So this is desert type A. So in the desert type B, what happens? Trochlea is flat, and you can see here, this is the crossing sign. This point is crossing sign. This is the trochlear line, and this is the condylar line. This has been crossed over here. So this is crossing sign, and another is trochlear spur. This is flat. So this crossing this trochlear line will extend anteriorly over the anterior condylar line, and this is known as trochlear bump or trochlear spur. And this is trochlear dysplasia desert type B. And another is crossing sign and double contour sign. See here, this is the double contour sign. It is because here medial condyle is hypoplastic. So the anterior medial and lateral patella line are not overlapping here. So this is the line of hypoplastic medial condyle. Hypoplastic medial condyle. So this is known as double contour sign, and this is desert type C trochlear dysplasia. And another is this is the crossing line. Trochlear line and intertrochlear line crossed over here. This is trochlear spot, trochlear bump, and this is the double contour sign. All three are present in this knee, in this femoral trochlea. So this is desert type D. And another important thing that we should not miss is a trochlear depth. You can see here. This is how to analyze this. We can elicit this information by drawing this tangential line from the posterior femoral cortex here, and another line perpendicular to this line. This is the blue line that is drawn at the point where the metaphyseal concavity ends and epiphyseal convexity starts from here, perpendicular to this line, and another line from here 15 degree to this line, and we draw this line and this point A to B here, this A to B distance is trochlear depth. So normal is more than 5 mm or equal to 5 mm. If it is less than 4 mm, then there is trochlear dysplasia. It is said that trochlea is shallow, and it is trochlear depth is, if it is less than 4 mm, then trochlear dysplasia is suspected. So another is axial view. This is also very important view. We elicit so many things from here, like general morphology, shape of the patella, trochlear dysplasia, and various angles and ratio. There is a paper by A.S. Panny, which illustrated that there is a patella shape can be a predisposing factor in patellar instability. So patellar shape definitely predisposes to the patellar instability. And Weaver has classified 3 types of patella. One is Weaver type 1, where the medial patellar facet length is almost equal to lateral patellar facet length. This is Weaver type 1. It is medial patellar facet length is smaller than lateral patellar facet. It is type 2, Weaver type 2, and it is very smaller. Medial patellar facet very smaller than lateral patellar facet. It is type 3. So type 3 Weaver type 3 patella is very prone to have patellar instability. And another things that we can see from the axial views, medial and lateral interspace. And in this X-ray, this is the lateral interspace and this is the medial interspace. Both are almost equal. The distance both are almost equal. You can see here, this is the lateral interspace B and this is the medial interspace A. And the ratio of the medial interspace to the lateral interspace should not be more than 1.6. This should be almost same length. So if it is more than 1.6, then it is said to be abnormal. That is, we can suspect there is patellar tilting. And another is sulcus angle. Sulcus angle. This is sulcus angle. To draw the sulcus angle, we have to take 3 reference point. One is the highest point of the medial condyle, and another is the highest point of the lateral condyle. And this is the trough of the trochlea, and we draw one line from here and one line from here. The angle BAC is sulcus angle. If this angle is the normal value of this angle is 138 plus minus 6 degree. If it is more than 145 degree, then trochlea is shallow. That is trochlear dysplasia is we can say there is trochlear dysplasia. Another is congruence angle. This congruence angle also gives about the information about the patellar tilt and patellar displacement. To draw the congruence angle, first one line is drawn. That line bisects this sulcus angle. That is AO. This line bisects the sulcus angle, and another line, reference line, is from this point A. This is the trough of the trochlea and median, the prominent median edge of the patella, and this line is drawn. So if this angle is toward the medial side, then it is negative. If it is toward the lateral side, it is positive. And average value is minus 6 degree. That means minus 6 degree is average value, and if it is more than plus 16 degree, that means if this line is in this side more than 16 degree this side, then patellar tilt. Then we know that there is a patellar tilt. You can see same thing here. This is the sulcus angle and this is the congruence angle. If there is more than 16 degree of angle, then we can see there is patellar tilt. So this view also, this view is very important to know about the patellar tilt, torcular dysplasia, everything. And another thing is lateral patellar angle of lowering. Here we can draw a line from this reference line from this joining these two condyle. One is this line and another line from the lateral facet, this line, and this angle should diverge. This should be divergent angle at the lateral side. Here we can see here, this is the this angle is divergent at the lateral side, and this is the normal lateral patellofemoral angle. And if this line are parallel, or if this line converges at the lateral side, then it is abnormal. So another is axial linear patellar displacement. This is not so much accurately calculated because of magnification issue. And how to calculate this is the lowest point of the trochlea, that is trough of the trochlea, and this is the median ridge. So one reference line from the medial and lateral condyle, we draw one line from here, then perpendicular to this median ridge, another line is drawn from the median line, and this distance should be less than or equal to 2 millimeter. If it is more than 2 millimeter, then we know that there is a patellar displacement, lateral patellar displacement is there, and this is also one feature of patellar instability. So the take-home message is patellar instability is very common problem. As Vivek already said, it is very enigmatic thing, and proper analysis of the X-ray will give us valuable information about the patellofemoral instability. With this, I conclude my presentation. Thank you.
Thank you, brother. I think the confusion of patellofemoral joint has been even more confusing because of all these lines and all. So patella is confusing because of all these, So still we have to learn, we have to know what it is. So are there any questions? Sir. I think Bhadrav, that was an excellent presentation.
Thank you very much. Well, I don't have question actually, but what I tell you that all of us we do X-ray for patellar dislocation, but very few will measure the angles.
Getting an appropriate lateral view or classification is really difficult. So what we have modified, that taking X-ray, because you are not controlling the X-ray. The people in X-ray department, they do, right, left, and center views, even if you write a two lateral view. So what we do actually is we take the patient to the operation theater, and then under C-arm, we take all these X-rays. We keep record, take picture of those, C-arm image, and then we measure. And then probably one thing which is very essential in patellar instability is understanding the disorder or the patellar trochlear dysplasia. And these were beautiful demonstrated. Thank you very much, Ganda. Good presentation.
Thanks.
So any more questions? So needless to say, these all lines and these all angles are useless if proper view are not taken. So lateral view should be true lateral. The medial and lateral condyles should be overlapped. If you could, himself, what he says is, if you cannot get X-ray from your X-ray department, go to Guwahati and get the true lateral X-ray from your C-arm, because that is very important. And even in axial view, the patella articulates with the trochlea at about 30 degree of flexion. So 30 degree of flexion view is important. We can get axial view in any angle. So Mozart is at 45 degree, Loring is at 15 degree, but true axial view where all these calculation can be made is at 30 degree. And in axial view, the lateral condyle to medial condyle ratio is almost about half. The medial condyle will be half of the lateral condyle in true best axial view. So that is very important. So any more questions, please?
Those who are
Vivek,
present online
Vivek, I
are-
have a question. Hello. Hello.
Yes,
Yes.
Vivek, axial view, you said you advise for all the cases for 30 degree. Or is
Yes,
it
sir.
so, or clinically you assess in what degree the dislocation or subluxation is occurring? Sometimes you in 30 degree, you might not get subluxation, dislocation. So in 60 degree, sometimes you get. So you advise all cases for 30 or clinically
Yes, sir.
on what degree you are getting subluxation, dislocation, at that degree you ask for axial view.
Sir, axial view X-ray should be taken at 30 degree, where the lateral lateral facet will be twice the medial facet. That is the true
Okay.
view where all these measurements can begin. This has scientific basis because at 30 degree, the trochlea, the nature of trochlea, the trochlear dysplastic trochlea is best seen at 30 degree, where the trochlea, the dysplastic trochlea is maximum at that point where the patella enters. So that is where we have to see, and 30 degree axial view is the master.
Okay. Sometime in certain degree, 30 degree, you might not get dislocation, subluxation,
True,
further
true,
flex.
sir.
So
True.
clinically, clinically judgment sometimes become necessary. Okay, all right. Thank you.
Okay, sir. Okay. Are there any questions?
Not only axial view, but also the lateral view, which is important to take it.
Yes.
So all these visual
So having-
classification is done.
Yes, having 30 degree view is not for seeing dislocation of the patella. So at the 30 degree, as you said, that we can analyze all those indices and line so that we can know that there is a dysplasia also. 30 degree is not for seeing whether it dislocates or not.
True, absolutely. That is the point, I think. So are there any more questions, please, for Bhadra? So excellent presentation, Dr. Bhadra. May I request our next speaker? We, since this patellofemoral joint, the investigation is the core part of this patellofemoral joint assessment. We have decided to split all the investigations in 3 different talks. Now let us hear about CT scan, role of CT scan in patellofemoral joint. May I invite Dr. Bidur Gewali. Share virus.
Thank you, Dr. Vivek. Respected Amit sir, all the seniors and my friends. Sorry. My topic is CT scan in patellofemoral instability. CT scan plots in right at the place where X-ray is insufficient, or we have already listened Dr. Bhadra talking X-ray is that complicated. The proper views are that is essential in a lot of indices and lines. And CT scan, using CT scan, I try to simplify a bit. Let's see how much I can succeed. Actually, CT scan complements X-ray rather than replacing X-ray. And the main advantage of CT scan is we can get axial sections, which is lacking in the X-ray. Axial section, and we can overlap the images and get a accurate measurement of various stuff. And this is the distinct advantage over the X-ray. Here are a list of parameters which can be measured in CT scan. Not all of them are that important. I would try to talk about the most important ones, like femoral neck anteversion angle, trochlear groove or trochlear shape, tibial tubercle, trochlear groove, TTTG distance, patellar height, patellar tilt, etc. And there are external tibial torsion angles like knee rotation angle, malleolar condylar angle, external tibial torsion angle, etc. The most important of the measurement, single factor that can influence the chronic and patellar instability is the trochlear dysplasia or trochlear shape. The normal trochlear groove angle, as Dr. Bhadra already mentioned, is 135, 136 plus minus 10 degrees. And any measurement over 145 degrees is considered trochlear dysplasia. Actually, Dijon et al. From initial his classification of the trochlear dysplasia, it has been modified several times. And the latest currently widely used classification is combined based on the lateral X-rays as well as CT scan. The type 1 trochlear dysplasia or type A is, in X-ray has a crossing sign. In CT scan has a flattened shallow trochlear group. The type B in X-ray has a crossing sign and supratrochlear spur, as Dr. Bhadra had also mentioned. And in CT scan, the trochlea seems flat in type B. In type C, and there is also a supratrochlear spur, of course. In type C, there is a crossing sign with double contour sign. Double contour is due to the hypoplastic medial condyle. In CT scan, we can appreciate the hypoplastic medial condyle very well in axial CT scan. In type D, there is crossing sign, supratrochlear spur, and also all of the three combined, double contour sign. And in CT scan, we can see it as there is a cliff, plateau and a cliff sign. The other important parameter which can contribute to the patellar instability is patellar height. Most of the indices of the patellar height, Dr. Bhadra has already mentioned, it can be measured in the lateral X-ray. However, the key is that it is very difficult to get a true lateral X-ray. However, this drawback of the X-ray can be easily solved by sagittal section of the CT scan, which can be used as an X-ray. And the commonly used indices, Catton design index, Insel Salvetti index, and we also have Blackburn peel. Every indices have a little variation, and Blumenset line also. The most important aspect, only CT scan can measure over the X-ray, is this TTTG distance. In this case, we use the two axial sections of the knee joint, one at the level of tibial tuberosity and other at the level of trochlear group. And we overlap the images. And the first line is drawn as the posterior intercondylar axis, joining the posterior aspect of both the condyles. The second point we identify is the deepest point in the trochlear group, this point. And we draw a perpendicular line from this point to the posterior condylar axis. In other line, we choose the center of the tibial tuberosity. This is blue line is the tibial tuberosity. We use the center of the tibial tuberosity and draw another perpendicular line to the intercondylar axis. And the distance between these two perpendicular lines is the TTTG distance. Normally less than 15 millimeter, 15 to 20 millimeter is considered as borderline, and any value over 20 millimeters is pathological. It will lead to patellar instability. Actually, although this is a simple measurement, there are various factors which contribute to increase in this measurement. Initially, these factors were considered equally important, but later on, studies found that this is very important factor, and many other factors, rotational malalignment, also contribute to the increase in this distance. In a study, the TTTG distance, this shows that study shows that when it is increased beyond 20 millimeters, the percentage of dislocation has linearly increased. It is actually not linear graph, it is exponential graph. It increases exponentially with the every millimeter increase in the TTTG distance after 20 millimeter. Other less commonly used index is the patellar deviation or patellar shift, which can be seen in axial X-rays as well. This is the measurement of the patellar deviation is quite similar to that of TTTG distance. One perpendicular line is through the trochlear group. The other line is the apex of the patellar facet. And the more the shift towards the lateral side, more chances of dislocation. And when the dislocation, when the shift is 35 millimeters, the chances of dislocation is 85%, as we can see in this graph. The other parameter is patellar tilt. Patellar tilt in CT scan is easily measured as compared to X-ray. we overlap two images, one at the cochlear groove and other at the little distally at the intercondylar posterior condyles. One intercondylar axis is drawn posteriorly, and the transverse axis of the patella, maximum at the level of maximum width, is drawn this line, and the angle subtended by this line to the parallel of the posterior intercondylar axis is considered patellar tilt. The cutoff value is 20 degrees. If the tilt is more than 20 degrees, it is considered that medial supporting structures are insufficient, or it can be indirectly used to identify there is MPFL insufficiency as well. Patellar tilt is also an important predicting factor of the risk of recurrence. Any value more than 20 degrees, the chances of dislocation gradually increases, and if the tilt is about 67-68 degrees, the chances is more than 78 up to 80% dislocation chances. The other is the neck anteversion angle. The neck anteversion angle and other rotational malalignments like knee rotation angle, external tibial angle, or condylar malleolar angle. These angles, these parameters do not directly contribute as a solo factor for the recurrence of the patellar instability, but they contribute in the various aspects of the malalignment, like increasing the TTT distance, or internally rotating the condyles, or externally rotating the tuberosity, which in turn will lead to patellofemoral joint insufficiency. This is how we measure in overlapping CT scans. Thank you. Any questions?
That was an excellent talk. So, if there are any questions on CT scan, use of CT scan, role of CT scan in patellofemoral instability, you are most welcome.
Can we just replace X-ray with the CT scan? These are all the. Can we replace X-ray with the CT scan?
In these few parameters, it seems so, but in practically we cannot replace that. In coronal plane alignment, CT cannot be replaced.
I'm from a time before even CT or MRI was there. You did point out that there are certain parameters which give CT for certain parameter X-ray is enough. For example, you did say that, but when you look for the lateral view parameters like the CT and the for that X-ray at a certain angle of the V, for example, 30 degrees. Do you need to do that in CT also or not? You can do a CT in a full extension and calculate the CT and such a extension. If it is not, I think.
That is the reason why CT scan cannot replace. X-ray is a dynamic measurement. It can measure in the various dynamics.
And I would like to put out something here that we have kind of excluded one thing, the clinical examination. Very important. Intentionally put in here because that is a different big chapter. So clinical examination, X-ray, CT, and even MRI should be taken on one big discussion. And I think most of the audience here, I think, does understand that clinical assessment, even ordering very interesting clinical assessment is a must. And then you can be directed at what you want to see. A lateral X-ray to see super X-ray or a CT, and the clinical assessment is actually for you to identify which properly.
Okay. There are studies of CT scan done in different angles. Some authors suggest that it has to be done at 30 degree of flexion. The CT scan also has to be done at 30 degree of flexion. But practically, these are different. So practically, if you do an X-ray at correct position, like we do, like Rizor itself says that probably getting an X-ray done in the X-ray department is not going to analyze. So when you take that patient, do under image intensifier, proper view, this will give you a lot of information. But some information, definitely for some information, CT scan will be required. and we will talk on MRI. Then you understand why we kept all these X-ray, CT, MRI. Then you understand all these lines can be drawn in different investigations. And then you choose your patient, which investigation should be your first time investigation. Any more question to be done? If not, I'll request Vivek Basukala to talk about MRI in particular instance. Thank you, Vivek.
Thank you, sir. Thank you, Amit sir. So now it's time to talk about MRI. So I'm not a radiologist. So talking about MRI in this much complex joint is the Herculean task. So let's see how much I will be successful. So let us start with the patellar tracking. This is how patella tracks. At 0 degree, there is no contact with the patella and trochlea. And at about 30 degree, patella comes in contact with trochlea for the first time. And this is the distal part of patella comes into contact with the proximal part of trochlea. And this is the lateral part of trochlea where the first contact occurs. And gradually, the trochlear contact area increases, and patella, the groove, the trochlear sulcus and the median ridge of patella will be perfect match, and there will be the patellar tracking. Wherever there will be problem with this natural process, there will be patellar instability. Be it the patella alta, where at 30 degree, the patella will not engage with the trochlea, that is only at 40, 50 degree patella will engage. Then there will be lateral overpull because of quadriceps and patella will dislocate. That is the mechanism of patella alta. And in trochlear dysplasia, whole of this trochlea is abnormal. That's why this normal tracking is not possible, because of which patella will dislocate. So we'll try to analyze how we can see these things in MRI. So patellar dislocation, we must not be focused only in the patellar knee joint only, because patella can dislocate from causes other than the knee joint. So this is extrinsic cause, like Amit sir and my previous speaker has already mentioned. The rotational profile of the lower limb can lead to the patellar dislocation because of change in vector of pull over the patella. So valgoid knee is again a risk factor for patellar dislocation. The flat foot, that is again a risk factor for patellar dislocation. And there are many intrinsic factors like patella alta. The patella alta, the higher position of patella, and the very famous trochlear dysplasia is also another cause, intrinsic cause, because of which patella will dislocate. And the another cause is redundant or non-functioning medial structures like MPFL and medial retinaculum. This is also a cause of patellar instability. And another very important cause of dislocation in flexion is the tight medial structures, because these are all things, these are all causes because of which the patellofemoral instability will occur. So I'll try to explain how MRI will help to identify all these things. So action plan, as Ishwar sir has already mentioned, first we start with clinical examination, then do X-ray. Nothing can replace. These are all complementary to each other. One cannot replace other thing. At least up to today's date, X-ray is not replaceable by CT, CT is not replaceable by MRI. We must do everything. So this is X-ray is first, then CT scan, and then the MRI. So let us start with acute dislocation of patella. What happens with acute dislocation of patella? First time dislocation is patella is because of some form of valgus overstress or some form of direct fall over the patella. What happens is patella dislocates laterally, and at that time the medial structures is ruptured and the medial facet of patella glides or it strikes with the lateral facet of the trochlea, because of which we will be finding the signal changes over the medial side of the patellar retinaculum and MPFL structures, and there will be some bone bruises around this medial facet of patella and lateral facet of lateral trochlear surface. So this is how it looks like. So this, in this picture, the medial side, the medial structures is ruptured, medial structures, the signal changes is there, and there is signal changes over the lateral facet of trochlea and medial facet of this thing. One very important thing which we must see in MRI, and only MRI will show that thing is the osteochondral fractures because of the blight, because of the impact over the medial facet of the patella and lateral trochlear surface. Sometimes there may be the osteochondral fracture of the medial facet of the patella or lateral surface of the trochlea. So this type of osteochondral fracture is not seen in X-ray. Sometimes it may not be even visible in MRI, in CT scan if it has no bone. So in that case, the MRI becomes indispensable, and only MRI will detect all these things. So wherever the cases with acute patellar dislocation with severe huge effusion, always suspect this thing and do MRI in those cases. This is osteochondral fracture. So these osteochondral fractures may be seen lying or floating in the huge hemarthrosis within the knee joint. So we can always see the axial image is indispensable in these cases where we can see this osteochondral fragment floating over this huge hemarthrosis, and even we can see the origin of this osteochondral fragment. Like in this picture, the osteochondral fracture is seen. The cartilage is continuous over this lateral facet, but this is absent from the medial facet. So this is the origin. This is the place from where this osteochondral fracture has arrived. And these cases are relative emergency, and these cases are the cases where the first time dislocators should be managed surgically. Otherwise, first time dislocators can be managed conservatively, and this should be fixed because nothing can replace the cartilage. So let us try to see recurrent causes of patellar dislocation, that is habitual causes of patellar dislocation. Cause number one is patellar trochlear dysplasia. According to these, are almost about 90%, more than 90% has some form of trochlear dysplasia in cases of recurrent patellar dislocation. This is Desert classification, crossing sign, supratrochlear spur, double contour sign, everything has been very well mentioned by Bhadra. And these same things can be seen very nicely, and even the cartilage morphology. There is a paper in which the cartilage shape, the shape of the cartilage and shape of the bone is not, there is mismatch between cartilage shape and the bone shape. So sometimes the shape of the cartilage, which is more important than the bony shape, is given by the MRI. So these are various type of images, various T2 weighted MRI image in axial cord, where you can see the types of the grades of trochlear dysplasia, type 1, type 2, type 3, and type 4. These are. So the place where these cords has to be taken is very important, because as we go on progressing distally, the trochlear depth increases. So the very first place where the cartilage is visible, that should be the main, that should be the place where the cord should be taken. And these are how it looks like. And this is another thing. This is lateral trochlear inclination. And this is again a sign of trochlear dysplasia. The lateral trochlear inclination is taken at about the point where the trochlea starts, that is the superior, as we go on cutting from superior to inferior, proximal to distal, where the trochlea starts, that is the level where we have to cut, and we have to take the line, that is posterior condylar line, parallel to the posterior condyles, and we draw a line tangent to the lateral femoral condyle. Then if this angle is more than 11 degrees, like this first picture is of normal trochlea, and second picture is that of trochlear dysplasia. If this is more than 11 degrees, then that is also a sign of trochlear dysplasia. This is again trochlear facet ratio. If this is less than 40%, that is, as I have already mentioned, the lateral trochlea is always larger than lateral facet of trochlea is always larger than the medial facet. If we take ratio of these two, this is taken 3 centimeter above the joint line. What is taken 3 centimeter above the joint line? And if M by L, that is medial facet by lateral facet ratio, is less than more than 40%, then that is also a sign of trochlear dysplasia. This shows the flattening, relative flattening of the trochlea. And this is trochlear depth. If the depth decreases, that is also a sign of trochlear dysplasia. So for this, we take a line, posterior condylar line, and perpendicular is drawn from this line to the lateral edge of the lateral trochlear facet at the midpoint, at the deepest point of the sulcus, and then the medialmost point of the medial facet. And the trochlear depth is average of these two. That is A plus C, measurement of A plus C divided by 2 is the trochlear depth. And trochlear depth is less than 3 millimeter. That is the shallow trochlea, and that is also a sign of the trochlear dysplasia. So these all things cannot be seen in X-ray or CT scan. This is the added advantage of MRI, where trochlear dysplasia, indirect signs of trochlear dysplasia can be seen and measured. And this is congruence angle of Marchand, where all these angles can be best drawn in MRI or CT scan, because while in the angles, the projection in X-ray may not be perfect. So these all can be drawn in the MRI as well. Next is the alignment issue, that is patellar height abnormality. Patella can be normal, patellar height can be normal, it can be patella alta or patella baja. Patella alta means higher patella, patella baja means lower patella. So this is a paper by Elizabeth Arendt, who is considered as queen of patellofemoral joint. And according to her, patellar height measurements on radiographs and MRI imaging patellar instability, and she studied about whether the measurement of patellar height in radiographs, the X-ray and MRI is same or not, because we are applying something which is measured in X-ray into MRI. That may not be same. This is the study, and according to her, every measurements sorry, every measurements in MRI, the measurements is higher. The measurements is higher. All of the measurements, be it the insult-salvati ratio, modified insult-salvati, Blackburn peel, or Caton-Decem, everything is increased in MRI measurements, and average increase was 0.1. 0.1 was average increase. So she advised 0.1 to be added in the X-ray, like we say, the insult-salvati more than 1.2 is patella alta. But if you get 1.2 in MRI, that may not be patella alta. It must be 1.3 or 1.4. So this is the inference from this study. And all these ratios which Bhadra has mentioned can be measured in MRI as well. And the modified insult-salvati, where the articular surface of patella has to be taken, this will be more perfectly taken in MRI because cartilage will be visible. So this is modified insult-salvati. This is Caton-Decem. Probably nowadays this is most commonly done for surgical planning. And this is the Blackburn peel ratio. Everything can be taken from MRI, measured from MRI. So this is Caton-Decem. I have stressed this again because most of the surgical decision in patellar height is taken from Caton-Decem. If this is more than 1.2 or by MRI 1.3 or 1.4, then it is the indication for patellar instability. Patellar instability treatment with TTO. Elizabeth Arendt has also mentioned in her paper that if more than 80% of patients will be undergoing height changes, that is tibial tubercle osteotomy, if only MRI value 1.2 is taken. So she advised not to take 1.2 as a critical at a benchmark for patellar height measurement. So this is again another thing, the patellofemoral index, which can be very well measured in MRI, not in other X-ray or CT scan. In this, some even David Dijuer claim that this is the de-investigation which should be done rather than all these ratios, because the patella will be articulating with the trochlea. And if a patellofemoral index, the patellofemoral index is abnormal, that is in patellofemoral index, the amount of engagement of patella with the trochlea is measured. So this is better investigation according to them. And for this, what they do is they take the maximum length of the patellar cartilage, and that length is overlapped. That length is drawn over the another image where the trochlea is highest. That is the cartilage of trochlea is highest. So and that line should be parallel to the first line. That is an ratio of TL by PL. That is trochlear cartilage by patellar cartilage multiplied by 100% will be the patellotrochlear index, and it should be more than 45%. So in patella alta, what happens is patella is abnormally high, so patellotrochlear index will be decreased. So according to David Gajor and from new papers, the patellotrochlear index is the investigation price in patellar height assessment, and this can be very well measured in MRI. Another is a measurement of TTTG, that is, this is measurement of lateral vector pulling by the quadriceps. And this TTTG measurement by CT scan has issues. That is, as the paper has mentioned, many paper has mentioned that as you flex, every 5 degree flexion will increase the TTTG, will decrease the TTTG distance by 1 millimeter. So this will be the angle dependent, the measurement where the knee, the position of knee, CT scan where the position of knee, it is dependent upon the position of knee when the CT scan is taken. Also, because the TTTG distance is very much dependent upon the rotational profile. Sometimes CT scan may be taken an external rotation of tibia or internal rotation of tibia, and accordingly that tibial tuberosity may migrate. So TTTG distance is again problematic. So this is the MRI is not solution to this, but MRI can take the TTTG measurement. But this paper has shown that MRI measurement of TTTG is consistently low by 2.3 to 3 millimeter. So if 20 millimeter is benchmark for surgical decision making from CT scan, for MRI that should be almost about 15 to 17 millimeter. So we must not take 20 millimeter by MRI. So this is how the TTTG distance is taken. The cut where the trochlear sulcus, that is trochlear groove, is deepest is taken, and another cut is taken where the patellar tendon just starts to attach with the the tibial tuberosity, because that is the point where tibial tuberosity is attached and the distance is taken. So another new variable that is only can be measured by posterior cruciate, that MRI, is tibial tubercle posterior cruciate line, that is TTPCL line. And some researchers have said that it can replace the the TTTG. The TTPCL normal distance should be less than 24 millimeter, and since it is only dependent upon the tibial parameters, that is tibial tuberosity and PCL, both are from the tibia, the femoral condyle is not taken into account, because of which all those angle issues and rotational issues with the TTTG will be neglected by this. So knee bending, rotation, and dysplastic trochlea where the real sulcus is not visible, these all can be negated by this TTPCL distance. But still, it is still in the stage of research, and this at present date it cannot replace the TTTG. So this is the paper where TTTG and TTPCL has been compared, and the conclusion of this study was MRI still cannot be considered to replace CT scan for TTTG, and TTTG measurement is better. TTPCL need further verification, and rotational profile can also be taken care by the MRI, and this is how it is done. There is more technical details. So thank you so much. I think the MRI is very technical. MRI is very complicated in this. So these are some of the MRI measurements, MRI techniques that can be used in the patellar instability. Thank you.
Thank you.
On God.
Hello.
Thank you, Vivek. I think that was a very good talk on reading MRI. Hello. 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 Are there any questions to?
Hello. Hello, I'm Dr. Chandra.
Sir, please, sir.
When you suggest a patient to do MRI, when you plan for surgery or every patellar dislocation?
So the question from Chandra sir is when to do MRI, whether to do in every patient of patellar instability or before planning for surgery. So I think the patellar instability patients, the MRI to be done in patellar instability patient when you plan for any surgical intervention. For the first time dislocator, for very low risk patient, if you do not consider that there is no osteochondral fracture, I think MRI is not that much mandatory. But if you consider, if you suspect osteochondral fracture, huge hemarthrosis is there, you cannot explain, the huge hemarthrosis is not explained by anything, the ACL is okay, everything is okay, then MRI should be advised. And in cases of chronic recurrent causes of the patellar dislocation, if you see some findings like trochlear dysplasia, the findings of trochlear dysplasia or patellar height issue in cases of X-ray or any other investigation, I think you have to advise for MRI, because in long run, these recurrent cases will have some cartilage issue, patellofemoral arthritis will be there, and MRI has added advantage of addressing or seeing these patellofemoral joint as well. So I think MRI should be done in almost all cases of the recurrent cases of patellar dislocation, and in acute dislocation, I think you can do if you suspect osteochondral fracture, otherwise it can be.
Vivek, what I personally do is for both acute and chronic cases, I always do MRI in addition to X-ray, because osteochondral fragment, especially the chondral fragment, which is very, very important, that will be detected only by the MRI, not by the X-ray, not by the CT scan, if it is a pure chondral fragment. So MRI is a must, especially in case of primary dislocation as well as in the recurrent dislocation. So if I plan surgery now for the detailed measurement, then I add CT scan. So my CT scan is the second choice, X-ray and MRI, and if required, CT scan is my choice.
Thank you, sir.
Yeah, I truly accept what Dr. Amit told, because it happened to me also. Few months back, the patient had first dislocations, and in X-ray I cannot see any fragment. But when I did, when the patients came after a few days, then I suggest to do MRI, and I found the chondral defect, only cartilage defect. So I think this is the very important that every patient with dislocation should do MRI.
True, sir.
So what Chandra is saying that recently he found out a case in which X-ray was normal, but when he did MRI, he found a chondral defect. So MRI is a must, either it is acute or it is a.
Thank you.
I tell you frankly that I do agree that when you have a distended, you have fallen knee with an unclear history also, and your clinical examination, you can't find something because in the distended, it means you can't do a lateral test sometimes. And I have come across, doing an MRI in such cases would help you to even make other diagnoses. There are cases like if you can't find a proper clinical history, they don't give a typical history. And similarly, even in patellar dislocation, you have a flexion external location and an abduction kind of injury history. Some cases are detected, thinking it was a patellar dislocation, but doing an MRI with an ACL. So when you have doubt and your clinical assessment does not give you that much of clue, and your finding is not correlating with diagnosis, I think it's good to an MRI. Besides osteochondral fracture and maybe an APSL suspect.
Absolutely. So in today's era where there are lots of litigation, where there are lots of things, patient will not say that you have saved my 7,000 or 12,000, but patient will say that's for sure that you have missed this diagnosis, because if you miss the osteochondral fracture for about 1 month, that is gone case. So I think doing MRI in acute setting where irrespective of everything is a good thing to go. So if there are no other questions, may I request Professor Amit Joshi for his second talk. That is about, he will be talking about principles of surgical treatment in patellofemoral instability.
I think back to back, there were 3 lectures on all the lines. Believe me, those lines were confusing, but you have to cross the line to go into the treatment. Without understanding, without crossing those lines, you'll not come into the treatment. And then probably all those, in the basics, why we divided that is we must understand value of X-ray, we must understand value of CT scan, we must understand the value of MRI to decide exactly what treatment option is going to be beneficial or suitable for this patient. So these are my objectives. I'll talk about basic understanding of treatment principles, how to decide which surgery will be most likely appropriate. I'll just touch upon David Dizor's famous a la carte approach, which I not always use this a la carte approach, share some of our experience in between all these cases. So let us start with the very straightforward case, 13-year-old boy, repeated injury of the left knee 3 times in number, all the times while playing football. So he was keen on going football. So when he came to us, when we examined, sorry, I don't have his in X-ray pictures or videos in the OT. This was in the operation theater. So he had this patellar dislocation. We did simple MPFL reconstruction for this patient. I'll not go into the technique of MPFL. And this is after 3 years, the patient is very happy. His patella is not dislocating. He's back to his sports, which is not very regular one, but he's playing futsal. He's very happy. Unlikely, another lady, 26-year-old lady, underwent 4 surgery for recurrent patellar dislocation. One of the out of these 4 surgery, one of the surgery was done by us long ago. She was not able to extend her left knee actively, difficulty in standing. I'll not go into detail of these X-rays. CT scan showed bilateral trochlear dysplasia. All the 4 surgeries were soft tissue surgeries. And this is what she came with us. One of that scar is ours. You see that she was not able to extend. She had to use her, other thing. Even after 4 surgery, this was failed. So case 1, after 3 years, both the follow-ups were after 3 years. Case 1 was a success, but case 2 was a story of a failed patient or a failed surgery. So what happened in the case 1? So it was just a plain patellar dislocation where the MPFL alone was injured. We repaired or reconstructed that MPFL. Then the patient was normal. But in second case, it was a trochlear dysplasia, patella dislocated, yes. But what we did, we repaired only or reconstructed only MPFL. We did not address the trochlear dysplasia. And then what happens? Abnormal bone and the patella again dislocated. If you remember that picture, it was in both the sides. The failed surgery was done, which was a soft tissue surgery. So the basic principle is bony causes of patellar dislocation cannot be corrected with soft tissue repair alone. So if you think that all the patellar dislocation can be corrected with MPFL reconstruction, ladies and gentlemen, that is a wrong concept. The bony deformities or bony abnormalities cannot be corrected by the soft tissue reconstruction. And that applies to everything. Talk about ACL, collaterals, PCL, all the ligaments. Where there is a bony abnormality, it cannot be corrected by the soft tissue. It will bound to fail. It's just a matter of time when your soft tissue reconstruction is going to fail. Again, coming to, I like Vivek showing the cartwheel of his causes, but fit that cartwheel into a simple 3 columns. You'll fit all the causes into these 3 columns. The soft tissue is not able to bring patella into trochlea. The trochlea is abnormal, or there is a malalignment of the knee. In all these 3 cases, your patella is going to dislocate. And this is essential to find out what has caused this patellar dislocation so that you identify a correct treatment. So if it is a high riding patella alta, then it is not only patella alta, it is the MPFL is also turned. Because of the patella alta, once patella has dislocated, your MPFL is turned. So if you see patella alta as just patella alta, your treatment is incomplete. So remember that in patella alta, that is the primary cause, and the secondary injury that has happened is the MPFL injury. So that is important. So what happens if there is a patella, what happens patella alta, it doesn't engage. So what we need to do is that distalize your tibial tuberosity by doing tibial tuberosity osteotomy. What you do osteotomy, remove 1 centimeter or calculated amount of the distal bone, and then you drag it distally, fix with the screw or whatever you want to do. Your patella will come down and it will engage. In association with that, you do a MPFL reconstruction. So this was just an example. This was a young 18-year-old lady. Young 18-year-old lady. You can see that she had a J sign, which is dislocation in extension. She had patella, trochlear dysplasia was not there. There was patella alta 1.4, Couta Dessin index. Alignment was normal, which is very, very essential to understand. Our MRI was also normal. So we did tibial tuberosity osteotomy along with the MPFL reconstruction in this patient. And you can see after 1 year follow-up, the patient is happy. There is no redislocation of our patella. This is, clearly united distalization of the tibial tuberosity, and the patient is doing well. What happens when there is a trochlear dysplasia? There is abnormal trochlea. The bone is abnormal. The path is abnormal. Your soft tissue alone is not going to put everything into the place. So in this case, when you are dealing with the trochlear dysplasia, think that there is abnormal trochlea, and because of abnormal trochlea, because your patella has dislocated, there is a MPFL injury as well. So what you need to do in this case is, first thing is trochleoplasty. So you need to correct the bony anomaly. You need to correct the bony deformity by making a groove, and then only your patella will track into the groove if you provide a groove. And association with that, you reconstruct the MPFL or the soft tissue restraint also, so that recurrence doesn't occur. So this was very interesting case. She was about 54-year-old. So she was tolerating all those things for last 25, 30 years. And when she came, this was her condition. Look at her left leg. So patella was dislocating right at, somewhere around 70, 80 degree. And she was not able to extend her knee because it remained dislocated on that side. So this was a clear cut from clinical examination, as sir was also saying, that this is a case of trochlear dysplasia. So any soft tissue surgery done in this case is going to fail. It is bound to fail like it failed in our initial cases. So what we did the detailed examination investigation for this patient. You can see that persistently dislocated patella in this particular patient. I'll not go into the MRI and the CT scan. But what we did in this particular patient is trochleoplasty, groove deepening surgery, along with the MPFL reconstruction. So we were addressing both the bony anomaly as well as the soft tissue anomaly that has been caused by the dislocation of the patella. And this is after 1 year of our follow-up. You can see the patella is sitting into the track. And this is what she's doing everything in 1 year time, and she was so happy. She's having a little bit of patellofemoral pain because of patellofemoral arthritis. She was having this dislocation for a very long time, but she was able to stand from a sitting position, which she was not able to do earlier. What happens in the valgus knee? In the valgus knee, the patella is tracking from the lateral side. So whatever you do to the soft tissue, again, until unless you bring the lateral pull into the trochlea, it is not going to heal. So this is another lady who had a, bilateral patellar dislocation. This is Vivek's case. That's why there is no proper recording of this case. I don't have a scanogram. I don't have a post-op follow-up. But what Vivek said, that we did this was the lady. I think if we have, you can see that the valgus knee. If we have video, I don't know. I'll show you somewhere else. If we have the video. So she had little bit of trochlear dysplasia as well, but she had clear-cut valgoid knee with the patellar dislocation. Okay, this is how she was walking, the valgoid knee, clear-cut valgoid knee, not able to clearly flex because at 30 degrees flexion, the patella was dislocating. And then this is what he did. Vivek did a beautiful, corrective osteotomy, the distal femoral osteotomy. And that's, he was saying, Vivek's word, that he was saying the patella is stable. If patella is unstable, here we have corrected only one component of the bony. So still trochleoplasty is not done. But since this was a disorder type A, we decided that if required, trochleoplasty will be done in the second stage. So in this case, the patient was stable. So how to decide which surgery is appropriate for a particular patient is very, very important. You think about what secondary condition are there to dislocate the patella. If there is a patella alta, then you have to distalize the tibial tuberosity. Otherwise, your patella is not going to engage into the groove. If there is a trochlear dysplasia, the trochleoplasty has to be done. If there is a rotational deformity, it has to be corrected, like Vivek corrected in that case, both valgus as well as the rotational deformity. The valgoid knee has to be corrected by the corrective osteotomy. If TTTZ distance is more than 20 millimeter, that means tibia is externally rotated, it has to be also corrected by medialization of the tibial tuberosity so that your pull becomes on the line of the trochlear groove. So the most important message I want to share with you is this slide. So surgical decision depend on the pathology causing the dislocation. It is not the MPFL alone. So if there is one pathology, you treat one pathology. If there are multiple pathologies, you must treat multiple pathology. You cannot treat correcting one pathology and think that all the pathology will be corrected. So again, to emphasize, identify the causes, identify the pathologies. If there are one, treat one, you are done. If there are multiple, all these causes has to be treated. Otherwise, the patella dislocation will recur. Just one slide about the a la carte approach. We all know what is a la carte. Order according to your demand. That is the simplest of the explanation of the a la carte. Whatever you want, you just order. So what Dizo say that MPFL reconstruction is must. Along with the MPFL reconstruction, probably most of the time you can associate TTO or the lateral lengthening or trochleoplasty or even osteotomy. So whatever required for the patient, you add to the MPFL reconstruction. That is Dizo a la carte approach. But many people, they do not go to a la carte. They think that probably we have to decide what are the surgery that is required for this particular patient before you undergo or undertake any surgery. So this is a very interesting case. Ishwar sir will definitely remember this case. This was a syndromic child, 13 years. Initially, he was operated at HRDC. He received already three surgeries, but he again came with the problem. And he was saying that both the patella dislocates more on the right side, and he's not able to walk because patella dislocates in flexion and he frequently falls. So that is why the patient came to us. And then we did a CT scan. There was an osteochondral fragment, even which was visible in the CT scan. TTTZ ratio was 25. You can see that. So what a la carte, in this particular case, we decide that we'll go ahead with the a la carte approach. We decided to do a lateral lengthening, femoral osteotomy since there was a valgus deformity, then MPFL reconstruction. And since this was a guy with tibial physis was not very much closed, so we decided not to do a TTO, but one modification of the medialization is the Roux Goldweth procedure for this patient. So this was the a la carte approach. Where are the pathologies? You identify what surgery is going to suit for that particular patient. And this is the follow-up after 1.5 years. Very smiley boy, and then he came with this all X-ray where everything, all osteotomies are united. And then this is what you can see that his right side, you just look at the right side, he was not dislocating anymore. You can see in the X-ray also, if you remember the previous X-ray, the patella was completely on the lateral femoral condyle, but here patella is sitting at the center. And the most happening thing was the patient was so happy that he could walk. And since he started rehabilitation, he hasn't fallen again. And I asked, your other patella is also dislocating. Let's get it done for your other patella also. He said that the whole aim of surgery was to walk without falling. I'm happy with this one. And see, he refused another surgery because he said that I have done multiple surgery on this case. So to conclude my talk and the case examples, from the case example is that the most important point is, don't think that a single surgery is going to tackle everything. A single surgery cannot tackle all the problems. Most important is to identify the problems, and the recurrent patella dislocation is a multifactorial. It's not only one factor. So if there are multifactorial, identify all the factors and treat them. Identification of each factor is essential to plan the treatment. That is why X-ray, CT scan, MRI, everything is essential. One is not replacing the other thing. It's very, very important. Each anatomical anomaly has to be treated. If it is a soft tissue, treat that also. If it is a bony, you have to treat that also. So whatever anomaly you have to treat each and every anomaly. And finally, remember that soft tissue reconstruction cannot compensate the bony anomaly. So all those surgeries, we used to do Campbell procedures when the proximal realignment surgery, they will fail definitely if your trochlea is not normal, if the bony alignment is not normal. Thank you very much for patience listening. If there are any questions, I'll definitely listen. Vivek.
Sir, I got one question, sir.
Sushil, just hold for a while. Dr. Vivek Banskota is asking question, and then I'll.
Okay, sir.
Okay.
Very excellent talk. I'm not a sports surgeon, my disclaimer, but recently Vivek, my other brother Vivek, sent me this. This was a young mid-30s lady who had instability. She had history of recurrent dislocation of the patella. The most recent dislocation was about 1.5 years ago, but she also had pain. So I was totally perplexed. In her X-rays, she had developed some patellofemoral fights, and when we discussed about the case, we were pretty confused. So I ended up sending the case back to the sports unit because we don't understand the relationship between pain and instability. And if both of them coexist in a patient, wow, how should we prioritize treatment? I think it's like opening a Pandora's box, but a little bit wisdom from you.
I think, you see, instability can also cause pain because its cartilage, which is very, very sensitive, will rub against the other cartilage and will cause pain. But instability, if not treated properly, will definitely cause osteoarthritis. And then osteoarthritis is going to cause the pain. So one of the reasons why, as early as possible, fix the recurrent patellar dislocation is to prevent the osteoarthritis. And as you very correctly said, that in case of patellar dislocation, it is the lateral femoral condyle and the patella cartilage that wears off, and then that is how the pain starts. So the treatment for these conditions are really complex, but you see, releasing the pressure between patella and the lateral femoral condyle. There are some surgeries advised to it, like Mackey procedure, in which you lift the tibial tuberosity so that there is no less contact between, if you give the Mackey procedure. And then of late, if the patient has grade 3 plus osteoarthritis, probably patellofemoral replacement is again coming up. Unfortunately, we don't do that. That's why it's important for all of us orthopedic surgeons to detect this patellar dislocation early. And like shoulder dislocation, if you go to literature, they said that the second dislocation is not the second dislocation. Second dislocation is a recurrent dislocation. So either it is a second or it is a 20th dislocation. So you consider them as a recurrent dislocation, and approach to recurrent dislocation should be completely different from the approach to acute dislocation. So current approach is aggressively addressing, because now we have various surgical treatment. So I think those cases with which Vivek said, patellofemoral arthritis with the pain, it's really difficult to treat those patients. Yes, Sushil, Sushil, you can ask your question.
Yes, sir. Good morning, sir. So my question is, in rotational osteotomy, do you need to be very precise by calculating and addressing all the angles in scanogram, or we can grossly correct them?
Sushil is asking if there is a rotational deformity, does it require a very precise rotational correction or gross rotational correction? I think, Sushil, I'm not a very osteotomy guy. Vivek does all those osteotomy, rotational correction and all. But, the whole principle of osteotomy is precise correction. So your overcorrection will also, cause problem. Undercorrection is also will cause problem. So precise correction, what is very, very important. That is why we need everything. X-ray measurement, X-ray alignment, CT scan measurement, MRI measurement, because rotational correction or alignment correction is a big undertaking. You cannot allow it to fail. So if your alignment correction fails, then you don't have anything in hand. So probably to tell you, it's difficult to precisely correct, but I think it is very, very important. Vivek, you want to add anything to that before we go to Ishwar sir?
Yes, these rotational abnormalities are the cases where you get wrong scanogram, because the knee, the femur is rotated internally and tibia externally. That's why the scanograms are taken. Usually, the X-ray technician scanograms are taken with the foot straight forward, and at that time the patella will be facing some other way. Every time in these cases, the patella must face forward, and in doing so, sometimes you will internally rotate the leg, and only at that point you will get the coronal alignment of these knees. These are the cases where mistakes can happen, and as far as mentioned, the overcorrection will lead to some new problem, that is iatrogenic. So absolute correction of this rotational profile is the must, and you should have a good pre-operative planning in these cases. The advice is address the place where the deformity is most. Usually, the proximal femoral osteotomy is advised, but many knee surgeons do distal femoral osteotomy or proximal tibial osteotomy in these cases, and the absolute correction is the must, I think.
Yeah, I think Sushil, I think we answered. Correct correction is required. Of late, we understood the importance of TTTZ, which will give us the tibial version and the tibial rotation, and the Staheli profile of the hip joint, which is very, very essential. In the CT scan measurement, in the MRI measurement, also Vivek said that Staheli profile, when you neck of femur and the femoral condyle is overlapped, and they measure the anteversion or the retroversion of the femoral health, that will indirectly tell you what is the rotational or what is the version of the femur. And probably this is the most important, and we were ignoring these things for a very long time. And that's why, since we were not understanding what is the deformity, we were giving a wrong treatment for most of our patients, which usually used to fail. Any other question? Ishwar sir?
Just two short comments. One for Vivek. That is a very interesting case. Like after I did my MS, I was, you all know, working at SRDC, and I was doing a lot of this congenital or the habitual dislocation, we used to call it there. And we were doing all this soft tissue, and most of them, 50% of them failed because, like we pointed out, we did not understand the pathology, the anatomy in the soft tissue. My personal experience, after I started having my private practice, you all know that one of the commonest cause of anterior knee pain is patellofemoral arthritis. And even before that, there is a thing called patellar maltracking. So I read a lot of books, considered dislocation of the patella and the patellar femoral instability or the maltracking.
Dislocation.
And if you look at all this patellar maltracking is written by sports surgeons, sports people. They talk about that. And the congenital dislocations, habitual dislocation is for the pediatric orthopedic surgeon. And in my practice, I would say, anterior knee pain, one of the commonest cause is some pathology of the PF joint. And this does come, and one of the most interesting things was one of our Zoom meetings, Dr. Clement Joseph was talking very nicely about that patellofemoral tracking, nerve tracking, leading to pain can be controlled by a lot of conservative. Okay, so that if untreated might have been the cause of the patellofemoral. Second, just commenting on it, just for the sake of discussion, cochleoplasty. What is the youngest age you can proceed with the cochleoplasty? Like find a cochlear dysplasia in the 8, 9, 10-year-old.
Yeah, sir. So we don't have any experience of doing trochleoplasty in skeletally immature. The general orthopedic knowledge of various books, they say that any bony procedure should be avoided. Probably Vivek will talk on that because his talk is in the pediatric. Next talk is in the pediatric and adolescent dislocation. general principle is that is the reason why we have not done. But there are sporadic cases when, at the age of 14, maybe post 14, you can do a trochleoplasty as well. Vivek maybe will talk about that. One last point I would like to say is also raised that.
Amit, I have a
yes, Navin, ask.
I have two simple questions. Out of all the procedures you do, if you have to give percentage wise, just MPFL reconstruction, tibial tuberosity transfer, and the tracheoplasty, what are the commonest which procedure, and you combine many of them? First question is that. Another is, in case of patella alta, usually I have observed, whether you have observed or thought or not, like in the acetabulum, if the femoral head is not in the acetabulum, in DBS cases, there are changes in acetabulum as well. So in case of patella alta, have you observed any change in the trochlea? Might not need surgery, but certain change in the trochlea if it is congenital patella alta for a long time. These are two questions I want to ask.
Thank you, Navin. Navin asked two questions. I'll go from the second question. He asked that in patella alta, did you notice that there is a trochlear dysplasia? I don't remember any, research being looked into this patella alta associated with trochlear dysplasia. But I take patella alta trochlear dysplasia as a two different entity. I identify actively patella alta and the trochlear dysplasia. As far as your first question is concerned, he asked what percentage you do MPFL reconstruction, what percentage you do TTO, what percentage you do trochlear dysplasia. My whole purpose is to, answer this question. There is no percentage in which you can do trochleoplasty or so you have to decide based upon the cause. So the percentage doesn't come in this one. If there is a patella alta, there is no point doing only MPFL. So percentage will not be there. So TTO along with MPFL. So based upon the disease, I do 100% the same thing. If there is a trochlear dysplasia, I do not do only TTO or only MPFL. I definitely do a trochleoplasty. So Navin, just to answer your question, there is nothing called what percentage you do and what percentage you do that. What is required for that particular patient, I do the same required, or what are the pathology, I treat all those pathologies.
No, Ella Carta approach, I understand. I mean, I just want to, because you do a lot, high number of cases, no? High volume surgery you do. So, as in my cases, probably in 80% cases, my cases suffice with MPFL reconstruction only. So, in that way, I am asking, what you need more. Yeah.
So, to answer your question a little differently, in acute traumatic cases, probably 99% it is the MPFL reconstruction. If it is a recurrent and the chronic traumatic cases, probably most of the time, either TTO is associated with it or the trochlear dysplasia, like trochleoplasty I do it. So probably that is how I best can answer. About
okay, thank you.
Last month only we evaluated of our 67 patellar dislocation over 4 years, and that is how we have come up with. Thank you, Navin.
One question from me.
Hajur, please.
Dr. Amit. So if the patients, I had one patient. If the patient comes with first-time patellar dislocations with cartilage defect, he is a 13-year and he has a trochlear dysplasia. So what your plan will be?
So if it is an adult, physis has been fused, I'll deal with everything. The cartilage, repair, either by suturing it back or fixing it back. So again, to reiterate for all the audience out here, if a patient with trochlear dysplasia comes to you with patellar dislocation and you did an MRI, you find out trochlear dysplasia, osteochondral fragment, how you'll tackle that patient. So I'm answering, if a physis is fused, I'll definitely do both trochleoplasty, fixation of the cartilage, and the MPFL. If physis is not fused, then I'll do probably MPFL reconstruction, Roux-Goldweth procedure, so that I more medialize the patellar pull and then the cartilage fixation.
Thank you.
Yes.
Regarding questions of Vivek, right? So, in any dislocation of the body, be it the shoulder joint or knee joint, what happens is there is stage 1 decompensation. At first, patient will compensate with his muscle, with active stabilizers, muscles and all. But there will be a stage where this will be decompensated, and that decompensation will start the arthritis. And after that decompensation, the pain will start. So in any cases of recurrent dislocation, if there is pain, there is starting of pain, that is not a good sign. That means we have seen the cases of shoulder dislocation where the shoulder had dislocated 50 times, 60 times. So the cartilage is very, very thin in those cases. So the dislocation is very bad thing. You have to tackle it aggressively. You have to address it aggressively very soon. Otherwise, cartilage issue will be there and you can do nothing. So once there is arthritis, metal in the body has to be put on. No other procedures can help that patient. That is the thing.
Thank you very much. So coming to the end of yes, anything? Keivo? Yeah, coming to the end of the talk, I would like to request again Vivek Basukala will be talking about how approach to a pediatric age group patient differs from the adult. Vivek.
So you just heard from Amit sir that the bony abnormality cannot be tackled by soft tissue abnormality. So I'll be talking about the condition where bony procedures is contraindicated because of obvious reasons. So what are the surgeries or what are the techniques by which we can tackle those cases without doing the bony procedure? That will be my talk for today. The pediatric patellar dislocation, how it differs from adult. The causes are almost the same. So at the very outset, this is very commonly taught and commonly told line. The children are not the small adults. So this must be understood thoroughly, because children has different physiology, kids have different physiology, different body proportion, different body structure. So all the procedures that has been described for adults will not fit in the pediatric population. So we have to deal with them differently. So this is patellar tracking again, same slide which I have shown. And this is again those causes, and these extrinsic causes are even more important in the pediatric population. And usually the first time patellar dislocation occurs in these cases where there is predisposing causes like the rotational extrinsic and intrinsic causes. Usually the first time patellar dislocation occurs at the pediatric age group, and after that the recurrence will go on, and after many recurrence, the patient will end up with patellofemoral arthritis. So pediatric population catching these cases at young age is very, very important. Catching these cases at young age is important because this has been shown, though it is controversial, this has been shown in many researches that just like DDS, just like developmental dysplasia of hip, if hip is not relocated, or if hip is not in the knee, hip joint, if the head of femur is not in the hip joint, the acetabulum will not develop. Accordingly, there has been many research animal studies where patella was intentionally dislocated and studied, and in those cases trochlea were not well developed. So trochlear dysplasia is the cause of trochlear dysplasia. We have seen many patients even in HRDC where we have done soft tissue procedures where one patellofemoral joint is stable, other patellofemoral joint is unstable. And in those cases, trochlear dysplasia, the depth of trochlea and all those in minimum type A trochlear disorder type A is found in those particular knee where knee is the patellofemoral joint is not reduced. And at about age of 8 years, the trochlea is maximally developed. So before the age of 8 years, if there are cases of recurrent instability in pediatric population, you have to do aggressive approach to get that patella inside that trochlear sulcus. So this is the patella. This trochlear sulcus develops over the mold, which is called patella. Patella is normal. Patella is almost normal, whether it is dislocated or not dislocated. The ridge is okay in every cases, but it is the trochlear sulcus where it is not developed. So to have good patellofemoral joint, good trochlear morphology, the patella should be replaced. So this is famous paper from Henry Dizor, the father of David Dizor. And he said almost about 96% of cases of recurrent patellar dislocation had some form of trochlear dysplasia. That might not be those severe form of trochlear dysplasia with surgery or trochleoplasty is needed, but almost 96% of cases of recurrent patellar dislocation had trochlear dysplasia. And quadriceps dysplasia, that is extension, lateral pull over lateral pull, was present in 83%, and aligned the high tissue, that is patella alta, was present in 24%, and TTTG abnormality in 56%. So this is obvious that trochlear dysplasia is common, and one of the causes of this much of trochlear dysplasia may be the not addressing these type of patellar dislocation, pediatric patellar dislocation as well. So this is the classification by Sital Parikh, which Amit sir has mentioned in his first talk. He classified pediatric patellar dislocation into acute, recurrent, habitual, and dislocated. In acute, there is with OCD and without OCD. In recurrent, there is subluxation or dislocation. Recurrent dislocation may be subluxation or dislocation. Habitual may be in flexion or in extension, and dislocated may be reducible or irreducible. The fixed dislocate, there may be some fixed dislocated patella where the reduction is not possible. So many cases of acute dislocation, if they have some predisposing factor like trochlear dysplasia, high tissue, these cases will go on to recurrent dislocation. Otherwise, many of these acute dislocation will not go for recurrent dislocation. So habitual dislocation are the cases where minimal trauma, just the dislocation may be atraumatic, and in habitual cases there will be 100%, there will be some form of predisposing factors like we have mentioned. So the traumatic dislocation, usually there are no predisposing causes, but traumatic causes, there 100% cases there will be some form of the predisposing factor. So traumatic cases are the condition where recurrence is very common. It's repeating again. So this is acute first time dislocation. This shows the patella dislocates laterally, and when it dislocates laterally, as I have mentioned in my previous talk as well, the medial facet of patella will hit upon the lateral facet of the trochlea, and by doing so, sometimes there may be just bony contusion, that is okay, but sometimes this sort of osteochondral fracture may occur, and these are cases of relative emergency, and we have to tackle these cases. So acute first time dislocation, you have to be very careful about osteochondral fracture, and if there are osteochondral fracture, you have to deal with it. So in recurrent patellar dislocation in pediatric population or in adult population, what happens is patella is dislocated laterally, mainly in patellar dislocation infection. What happens is there is tight lateral structures. The tight lateral structures are quadriceps. The rectus may be tight, and the vastus medialis, even vastus lateralis, and tensor fascia lata, even the biceps femoris, and even sometimes the hamstring and posterior capsule will be tight. So it is impossible to reduce that patella without releasing all these tight lateral structures. In fact, in some cases of patellar dislocation, what happens as you go on flexing these knee joints, the flexors, actually these muscles are the flexors of the knee, extensors of the knee joint. Because of lateral position of these muscles, these become flexor. So this is that severe. So all release of this thing has to be done, and there are many techniques, soft tissue techniques that has been mentioned, like release of quadriceps, the vastus lateralis and the rectus femoris, the release of lateral retinaculum, and sometimes the proximal realignment. If by doing release, again, you will have multiple times we have that type of situation where patella is now tracking, patella is now over the femoral trochlear sulcus, but it is so tight that range of motion is gone. In those cases, the lengthening of quadriceps has to be done, that is the quadriceps plasty has to be done. Sometimes distal realignment has to be done, because sometimes the patella, there may be patella alta and bony procedure cannot be done. In those cases, distal realignment, that is double breasting of the patellar tendon can be done. This is soft tissue distal procedure. Sometimes this is the technique called Rugolvik procedure, where distal realignment, the lateral half of the patellar tendon is cut and it is transferred medially so that the resultant vector will be more medially. So this is Rugolvik procedure. So habitual dislocation can be in flexion. So these are because of tight lateral structures, tight and short quadriceps, tight ITB, patellofemoral and patellotibial ligament tightness may result in habitual dislocation in flexion. In extension, patella alta, trochlear dysplasia. Trochlear dysplasia is tricky. It can dislocate in flexion, also in extension, and MPFL insufficiency also lead to dislocation in extension. So habitual dislocation, pediatric patellar dislocation, I think we are the luckiest because many of such patients come to HRDC and we get lots of patients, variety of patients with dysplastic trochlear, dysplastic patella. So we have been doing a procedure just like Amit sir has mentioned. We identify the cause and tackle individually. That is the a la carte approach. We do 4-in-1 approach where what happens is the medial redundant structure, that is the many of these cases, pediatric cases have the hypertrophied or long quadriceps, medial quadriceps and medial retinaculum, and the lateral structures are very tight because of it the patella is dislocating laterally. So what we do in these cases is, this is short animation which shows the medial loose structures and lateral. We do not do complete lateral release. We do lengthening. We cut lateral structures into two halves, superior and distal, and we lengthen like this. The deep part is sutured with the proximal part, and by doing so, this, let me go in. So this is, we cut into two parts, that is the superficial and deep parts. Superficial part is transected just lateral to patella, and deep layer is transected just near to the attachment of the this retinaculum. And after that, what we do is we suture this superficial layer of posterior part with the deep layer of anterior part. By doing so, we get the length, we get the lateral lengthening and lateral success. By doing so, only the patella will come and realign with the trochlear sulcus. What happens if we do complete release is, what happens is, sorry, because of pull from the medial side, the patella will tilt. So that tilting of patella is, this is what I was mentioning. So this type of, if you do all the procedures, that medial tightening, when you finish your medial tightening procedures, if you do not lengthen, if there is no restraint in the lateral side by lateral lengthening, if you do complete release, patella will tilt. Now you will have whole set of new problems. So patellar lateral retinaculum lengthening is the way to go rather than the whole complete release. And what we do in these cases is the redundant medial structures which was there, we cut at the level of medial side of the patella, and we get all those things over the patella and suture it back with the superficial layer of the previous part. So that is called quadriceps plasty. We do tube quadriceps plasty, and finally we do distal realignment as well. And that distal realignment is the Rugolvik procedure. What happens? The two vectors, there will be resultant vector which will be more medialized. So this is the animation of our procedure, and this is how we do. See, every time we flex the knee, the patella is dislocating laterally. And what we do is we do the lateral success so tight that it is irreducible in flexion. And so we do the midline incision, we do subcutaneous dissection. This is what I was talking about, the lateral, and sorry, there is a medial lengthening. Actually, it is lateral lengthening. We dissect lateral retinaculum into two layers, the superficial and deep layers. And by doing so, this is deep layer being dissected. See, this much of length we will be gaining. Now we are doing the distal realignment procedure. This is patellar tendon, and we will cut this patellar tendon into two halves. The lateral half is cut from its attachment, and it is brought from under surface of the medial half, and it will be attached with the periosteum over the medial side. So now the turn is of medial release. We do extensive medial release from quadriceps to whole inferior part of the tibial tuberosity. So this is some dysplastic trochlea, and after that we'll harvest the MPFL. And now we are completing the Roux-Golvith procedure. We do everything first. We release everything first. This is the tube quadriceps plastic. This is the tube. Okay. So this is tube quadriceps plasty. Whole BMO and quadriceps is brought over the patella and sutured with the lateral superficial retinaculum. So by this, the redundant lateral structures will be taken care of, and it will act as a medial support to hold this patella from dislocation. So this is the tube quadriceps plasty. See, without adding MPFL, the patella is tracking nicely. Now, finally, the lateral lengthening is being closed, and whole of the lateral structures are lengthened. This is how we have lengthened the lateral structure, almost 3 centimeters we have gained. And final thing is, in all a la carte approach, add MPFL. MPFL has to be whether in adult population or pediatric population. We are adding this MPFL. We do superficial quadriceps flip technique, and as we cannot do bony procedures, we cannot do bony tunnels. The Sauté point procedure, which we do in adult, is not possible in this case, and we tie this MPFL graft onto the adductor tendon like this, and we suture the redundant graft again with the adductor tendon. So this is our way to go procedure for patellar dislocation, and we've been doing this procedure in HRDC very often, and we have some few follow-up cases, and the patients are very happy. So at the end, thus we'll close rent over this adductor tendon as well, and this is the stability that we'll be achieving after the procedure. See, the patella was very dislocating with every flexion. Now the patella is very stable. So this is our way to go procedure. Thank you so much. If there are any questions.
If there are any questions, I think pediatric age group patellar dislocation is a very complex stuff, because we are addressing against the principle of treatment of the patella. As I said, the principle is, if there is a bony anomaly, treat bone. If there is a soft tissue anomaly, treat soft tissue. But in pediatric age group, as you know, that we are not able to do a bony surgery, so that we have to get away with the soft tissue surgery. That is why the pediatric patellar dislocation has a higher rate of recurrence compared to the adult recurrence. So whenever we treat this patient, we have to be very careful, counsel the patient, activity modification, and then follow the patient up for a longer duration and explain that if required. Explain the same thing. You have a bony problem, we have tried to correct with the soft tissue. If your bone doesn't remodel, then probably you will have a recurrence in the later dates, and that may require a surgery. Probably that is what said to go. But I think Vivek showed a 4-in-1 procedure, which we learned from Sheetal Parikh himself in a very intensive, what is that called, webinar, And then we have done around 11 cases of 4-in-1 procedure, and touch wood till date, the results are good. And that is what Sheetal Parikh said, that 4-in-1 procedure is the way to go procedure, because it tackles proximally, it tackles distally some part of the bone. Like TTO will invariably medialize the patellar tendon. So in this case, he has added Roux-Golvith, which will a pediatric conversion of a tibial tuberosity osteotomy. I think, and then Rizor also said that tibial tuberosity osteotomy, probably we are always underdoing tibial tuberosity osteotomy, because
it not only inferiorizes the patella, but also medializes the patella. That's why tibial tuberosity has to be done more frequently. And that is what Seetal said, that probably in all his cases, irrespective of rotational anomaly, he does a root cold procedure because the vector of the pull is on the medial side. If there are any questions to be raised, please.
How will you know that there is tightness in the lateral structure? Is there any case or you feel it lateral structure or any case? And another question is, how do you decide that lateral structure should be released or not?
So, Badra, that was wonderful question. So, how to test tightness of laterals? It is clinical examination. So we do the SAGE test, the quadrant test. So if it is not going more than 2 quadrants, then that is tight lateral structure. Tight lateral structure will be invariably present in cases of patellar dislocation, be it adult or pediatric population. In recurrent dislocation in flexion, the tight lateral structure is the first thing that you have to tackle. And the clinical examination is how you see it. And as when you try to do flexion and you try to relocate that patella with force, if you cannot do it, that means there is tightness. And what was the second question? So I think that is again there is change, paradigm shift. Previously everything used to be cut, everything used to be released, but as I have already mentioned, as you are adding some form of medial resistance in form of MPFL or quadriceps plasty, it will lead to overpull from the medial side and there will be tilt of the patella. So it's good to lengthen. It's good to lengthen than completely cut, because there will be nothing left if you completely transit, because patella will pull and there will be whole gap. So I think it's more anatomical and more scientific to lengthen than patella.
I think for 2 reasons we should not release. It has to be lengthened. And the picture of releasing the lateral structure is completely out of picture now. One reason what Vivek said, that if you pull from medially and the lateral side is released, the patella will tilt and the patient will have severe pain, restricted movement, and the chances of dislocation is again high. The second thing is, if you leave vacuum, the nature will not leave that as a vacuum. So there will be a fibrotic tissue. And we all know that fibrotic tissue, they contract severely. So if you leave it open, the fibrotic tissue will come and then they start contracting and then pull it laterally. So the chances of recurrence is very, very high if you just release. That is why Vivek is saying that if you lengthen, if you are not able to close, because the lengthening is very big, not able to close, take fascia lata, freeze that gap. Don't leave any gap in the.
Thank you for a wonderful presentation. Just from experience at HRTC, we do a lot of growth modulation for so where in your menu would you put that? Because fortunately, that is a very, very simple procedure and very powerful procedure, because it can give you up to 12 degrees of valgus correction for your distal femur and tibia. So where would you put it in management of tibia?
So coronal imbalance or coronal deformity of knee, everywhere the bony procedure is first, because bony, I always say bone is like pillars, and every soft tissue, these muscles and all are just like these walls and all. So your pillars has to be strong first. That's why bony procedure, the alignment issues should be taken care of first, then only soft tissue procedures has to be done. If you do concomitant, or if you do simultaneously both procedure, the amount of release, amount of that thing, or number of procedures, soft tissue procedures that has to be added will obviously decrease with the coronal realignment. I think the bony procedure should be done first.
Yeah, I absolutely reiterate the same thing. If a kid with valgus deformity with the patellar dislocation, first thing is to correct is the valgus deformity. That is by growth modulation, doing something to the physis and growth modulation. Once the alignment is corrected, that is the time when you dislocate. So what you do in between that thing, the patient is dislocating all the time. What you do is reduce his activity level, ask the patient to be less active, and then you try to modify those things. But if you do reconstruction patellar or patellar surgery without correcting the valgus, it's bound to fail. 100% failure from the day one. If there are any more questions, no question from the audience as well. If there are, yes.
For pediatric, since it is a soft tissue procedure, I think what we do is we keep the patient in posterior slab in full extension of knee joint for about 1 month. Then we gradually start the range of motion. That is our post-operative protocol. So unlike bony pressure, we can not give range of motion straight away. Still, sir. That is under anesthesia, sir. Muscles are all relaxed. After patient comes out of anesthesia, these muscles are so violent. It can contract so violent. Patella fracture garaidin सक्छ. So this is so violent.
I think that is how in the same unit myself and Vivek we differ. I always, whenever I do any bony reconstruction or a soft tissue reconstruction, I always check what is the safe range of motion in the operation. So you see, one of the complications of all these surgeries around the knee is stiffness. So you have done so much of correction when the patient lands up with the stiffness, it doesn't make any sense. So I check basically, Vivek doesn't, he's more protective. Although I'm old, I'm more aggressive in rehabilitation. He's young, but he's less aggressive in rehabilitation. Okay, Vivek, thank you very much. So on behalf of AKB Center, I'd like to thank all of you for being here. This is our new OPD block. So this is not a hall. So our meeting room will be made soon, and hopefully next meeting will be our meeting room. This is a hall which we converted to a meeting hall today. And then I'd like to request Director of AKB Center, Dr. Ishwar Pradhan, to say a few words, because you are the oldest one I see here.
Two things. First of all, thank you for all of you coming. The Saturday also you are here. This is very encouraging. As a past president of ASON, I feel that this is a big achievement for the whole team. That even on Saturday we have a big gathering to discuss one of the most pertinent problems. This is a problem. Like I said, I started by doing dealing with the congenital dislocation with a total open procedure. Now I understand that there is more to it than just doing a simple soft tissue release, and I am glad that I have my younger colleagues, more expert than me in delivering such good topic of discussion, so that the whole community, people interested in arthroscopic procedure and all these topics can be benefited by our experience. We are always there to promote this. Thank you for coming. We hope that we will be able to conduct more of this kind of discussion, academic things, and the ASON people are always here. Thank you for giving us the opportunity to conduct this meeting here. Thank you.
Thank you so much. So we'll be closing our, we'll be stopping our Zoom telecast. Thank you so much, all the participants from Zoom. Thank you so much.